My name is Alison Richmond and I am the Quality Improvement Lead Nurse for West Yorkshire Critical Care Network. So a little bit of background around the network. It's operated in its current format since April 2013 and it's a regionally based collaborative partnership funded via NHS England Specialised Commissioning, and it's hosted by Leeds Teaching Hospitals, which is why I've been able to undertake the Leeds Improvement Method training. The network function and governance arrangements are described in the NHSE network service specification and include reporting arrangements aligned to the integrated care boards in collaboration with NHSE specialised commissioning teams and acute providers. The network is made up of 6 acute trusts who collectively serve a population of around 2.3 million. So that includes Airedale, Bradford, Calderdale and Huddersfield, Harrogate, Mid Yorkshire and not Leeds. Next slide, please. So my project was around improving the return of inter-hospital transfer forms. So all patients who undergo a critical care inter-hospital transfer, which is the transfer of critically ill patients from one hospital, which is usually the ED or intensive care unit, to another intensive care unit in another hospital, must have a inter-hospital transfer form completed. This is a standardised form used by all acute trusts in West Yorkshire and fulfils the requirements of the Intensive Care Society and the Faculty of Intensive Care Medicine in terms of the data fields collected. It's a multicoloured triplicate carbon copied form. The white form is retained by the receiving hospital in the patient notes. The yellow form is retained by the transferring organisation, and the pink form is returned to the network for audit purposes. Next slide, please. So the guidance that's available to us states that the standard transfer documentation must be completed for all intensive care patient transfers and must be scrutinised with robust audit systems, allowing for eventful or substandard transfers to be investigated and lessons learnt. So our problem and our challenge is that not all transfer forms are returned to the network. Although we have the standard transfer form, we have low numbers of forms returned to us, and therefore we're not able to meet the national standards in our ability to audit and scrutinise the transfer forms. And as I said, we can't share this learning across the network. So the challenges are that we need a reliable baseline data for the total number of transfer forms to gain accurate percentage of transfer forms returned to us. And working with 7 organisations, 12 critical care units, 9 EDs, with a range of different IT processes and IT systems causes a challenge for us. At the time when I started this project, we didn't have a network transfer forum to act as a communication channel. And the forms are generally returned to us via post, so that's an additional cost from the postage. And in an evolving digital age, we were still working on paper, and at the time we still have minimal links with EDs. Next slide, please. So utilising some of the these improvement methods that I learned during the programme, the PDSA cycles and doing the Gemba walks, we took some actions. So what we did is we appointed a network transfer clinical lead in the absence of a regional critical care transfer service. We were able to therefore re-establish our transfer forum and open those communication channels back up. And we already utilised the transfer training course to communicate requirements to return the forms. We needed to understand the different processes that each of the units use to return the transfer forms, and doing the Gemba walk helped us engage with colleagues on each unit. We needed to also build on previous project of providing self-addressed envelopes to encourage return of the transfer forms, and we needed to look at retrospective data for the number of transfer forms received and versus the number of transfers that were taking place. So what we did is we circulated pink wallets to all critical care units via the transfer forum representatives in order for the transfer forms to be collated and then returned to us in batches. And we also offered the option to scan forms back to the network email address. And we expected that both actions would result in a more convenient way to return the forms and result in cost savings through reduction in postage. And we were also able to fulfil the requirements of auditing forms and learning from eventful events. Next slide, please. So we were really pleased, and it did take some time. There was a bit of delay in returning some of the transfer forms to us, but this graph demonstrates the improvements in a number of transfer forms returned to the network. And as you can see, there's an upward trend there. So the green arrow indicates when we first started with the poster project of a colleague and the envelope project, and the pink arrow indicates when we released the pink folders and the scanning option to the units. So we're really pleased with that forecast, and hopefully that is going to continue. Next slide, please. So what went well? We're really pleased with the engagement and collaboration through the Gemba walks and the discussions with our colleagues on units to understand the processes currently used. The actual idea of the pink form came from one of the units when we requested ideas of how we could make an improvement, and the re-establishment of the transfer forum allowed us to have increased in communication channels with all the units. And we were also able to get more reliable data from our Medicus platform, which is an electronic platform that is used to collate ICU data that's used by all trusts. So we're able to have more reliable data around the number of transfer forms into our units. And next slide, please. So my final slide, and although we have seen an improvement and we'd like to see that improving even more, what more can we do? Well, we intend to do a root cause analysis and return to the Gemba to understand how units are implementing the new process. Can this be replicated where units are not having as much success? It may be that there's more than one solution. We still need to increase engagement with our EDs to make sure that we're still getting as many forms back from those EDs as possible. The transfer lead is now starting to analyse the returned forms to allow learning from eventful or substandard transfers, so we can continue that learning through the transfer forum. And we'd also like to improve the completeness of the transfer forms to make sure that all fields are completed. Our ultimate aim would be to have an electronic solution, but that would involve multiple agencies and quite a significant amount of funding. So thank you for listening.
Thank you, Alison. That's really interesting. It's amazing the kind of things that go on between hospitals, isn't it? No,
yeah.
You never quite know what's going on. I'd be fascinated. I don't want to do it now because I think I'd be kind of taken as a bit off piece, but I'd be quite interested to sit down with you outside of here and talk through the process and maybe discuss with a couple of my colleagues in the digital team what we know about what's out there and whether there are some opportunities to look at digital options. I mean, I don't know if there are, but it just feels to me like you say, it's very analog in a digital world, isn't it?
It is, yeah. And really happy to have those conversations. That'd be fantastic. Thank you.
Great, thank you. Amy, over to you, please.
So hi everyone, my name's Amy. I obviously work for the Workforce and Education team within the Chief Nurse CSU, and I'm here presenting about the care certificate compliance and our deep dive into achieving a green report. Next slide, please. So the care certificate was developed really in the wake of the Francis Report and Cavendish Review, and it is a defined set of standards that equip healthcare support workers with assessment criteria to fully embed their learning outcomes when they are caring for our patients. The care certificate was designed by NHS England, Skills for Health, Skills for Care, and that was really to have a consistent approach to care delivery at all levels, whether it be in the acute sector, private sector or social care. And the care certificate compliance for our organisation, when our team took it over, was around 65%. And we had a trust target for Leeds teaching hospitals of 80%. Now, we are a team that does tend to ask why and why not, and we do tend to have a, well, let's try ethos. So we were really, really passionate for our patients to get that compliance up so that we were assured that all care delivery was informed in relation to the standards that were being taught to our support workers. So we reviewed all the members of staff needing the care certificate, and we used our digital systems, mandatory training, reporting suites, and liaise with workforce intelligence. And we also realised our strategic priorities in line with our trust commitments. So we appreciated the use of our existing digital systems, but we also wanted to show that kindness and compassion to each other, to our CSUs, to our trainees, and to the team that were working on this project. Next slide, please. So we had to look at our educational delivery models that used the care certificate for our organisation to make those improvements. And there were two models. One of them was new to care, and one of them was called the Care Certificate Programme. For the new to care, the new to care programme is designed for healthcare support workers that don't have any care experience, but yet demonstrate those values to care. And that is a 3 weeks face-to-face training preparation programme. And it also uses a targeted approach and celebrates the diversity of the communities we seek to serve in and around Leeds. We do a targeted approach of around 50% of people that are from priority 1 ward areas within and around Leeds that come and join our new to care programme. So minimal changes really were made to that educational delivery model, but we did align some of our completion and reporting dates for the care certificate. Now, the care certificate programme, that is an educational delivery model for everybody else who joins our organisation outside of the new to care route. So it might be AHP support workers, clinical trials assistants, radiology, any other unregistered patient-facing role. And we actually removed 4 face-to-face study days off that programme because we were realising that with a compliance of 60 to 65%, what impact were those study days making? And we were really, really passionate about releasing that time to care back to our patients and to our ward teams. So we looked at the National e-learning for Health platform, and I liaised with NHS England to ensure that the robustness really of the programme and that it met the standards that we needed for our teaching and for our outcomes. And we aligned both programmes to ensure that we were completing on time, we were uploading ESR updates on time, and that everybody was supported. We used the Leeds improvement methodology. You can see there on the slide with the Gemba rounding, we looked at the efficiency in our cycle times, and we honestly could not have made the improvements that we have without that Leeds improvement methodology and the support from the teams. But we also got quite competitive and we were setting some healthy goals. So we were very much like, well, if the trust are happy with 80%, then we'll get you 90%. And it was really good to see the team getting on board with that approach and that healthy competition. So we engaged the team right from the very beginning. We did use KPIs, production boards and production boards meetings, and we also used some colourful sticky notes to engage our creative brains. Next slide, please. And these are just some pictures really, and I'm pleased really to say that our production board has had an improvement as well, which is the bigger picture in the middle at the bottom, and then that's just a picture of the team to the right, because the team were very much engaged at the very beginning. The sticky notes are where we looked at our duplications, we looked at our waste, we looked at how we could improve, what we needed to do. And then we looked at the production boards and then how we could improve, and how I could be the leader of those production board meetings. And the production board is brilliant, really, because we all know our business every day, and the care certificate compliance is a very, very small piece of our workload, but the work streams run really efficiently with the use of those tools. The next slide, please. So these are some of the existing metrics. I'm not sure if you can see it very well, but the white table to the top left, that was 2021. It's obviously got all of our CSUs to the left and the compliance. And the compliance is at the bottom, and the care certificate compliance is around 65% on average. And at the end of May 2021, I think the compliance is around 78%. The next to the top right is the care certificate compliance for our CSUs in 2023 to February 2024. And you can see at the end of February 2024, from the end of May 2021, there's been really no difference in that care certificate compliance for our organisation. They did implement a RAG rating, really, with a red, amber, green for our CSUs so that we could target areas that were needing more support. And then our team took over the care certificate compliance work in May of 2024, and we were really driven and really quite determined. And we did a lot of work with our CSUs, and we really, really wanted that all green report. So this is what the all green report is at the bottom. And it upset me in June a little bit because we almost got that all green report, but we weren't quite there. And then in August 2024, if you look at the table, we thought we'd got the all green report, but then we realised that our research and innovation team, although they held their compliance locally, we weren't capturing that in line with all of our other reporting suites. So we got them on board, and finally we got that all green report in February 2025. However, the success with this is we did finally achieve over 90% in September 2024, and we've actually maintained our care certificate compliance, and it's sitting around 94%, and that's from July 2025. And for an organisation of our size, I think 94% of people completing the care certificate is wonderful, really, for our patients. So next slide, please. So what went well? So going electronic, reducing those wastes in time, reviewing our educational delivery and our materials. We really enjoyed working with our CSUs and having that visible approach, and I think embedding the messages of our improvement work really, really helped. They understood, well, we all understood the importance that this would have for both our patients and for our staff, and having that visible presence being reinforced. We have had some success through Time to Shine. We were the most inspiring team locally, and then nationally from the Nursing Times Workforce Awards, we won the Workforce Team of the Year. So we're still in shock from that, even though that's a year on nearly. But that was from all the improvement work that we were able to demonstrate at shortlisting, and yeah, we won that. So next slide, please. So what would we do differently? It's absolutely fantastic that we've got a compliance of 94%. It's absolutely wonderful that we have improved from 60% from 2021, and we've done that in quite a short time. I think we took over May 2024, and consistently now we're improving that all of the time, and the team are fundamental to all of this work. However, what I really want to capture now is that impact. So what impact does that have for our ward teams and our staff, and most importantly, our patients? It's great that we can say we're at 94%, but what is the difference seen at ward level with our patients? And I'm really interested for the next steps to capture that, whether it be through professional discussions with our ward teams afterwards. We get feedback on the programme, but we're not getting feedback about the impact on the wards. So that's our next steps, what the impacts has. And thank you for listening.
No, thank you, Amy. That's fabulous. I think really interesting the way you kind of think about where to go next with it as well. You know, considering that direct impact on patient care. So fabulous. You can see all the clapping and the hearts coming out of the audience. We've got a few minutes for questions for either of our presenters. Does anyone have anything they'd like to raise with either Alison or with Amy? Jenny?
Lovely presentations, both. Well done. Really, really. And both just so directly impacting patient care. I guess the first one is Alison, in terms of sort of where the data, I think it's brilliant, the work that you've done, and we want to be data informed, don't we, for improvement, and we can't improve if we don't even know where we're starting. So I just wondered if you could say a little bit more about how that data gets used then in the network to inform the improvement. And then the second one was for Amy, and I might have what was from those going through the care certificate as well, sort of, because it's a big change, isn't it? So two questions, one for each of you, please.
Thanks, Jenny. So how is the data used across the network? So we're very lucky that we've got really good collaboration with all the acute trusts within the network. So we share all the data that we receive via the transfer forum, which has got representatives on there from medical leads, from critical care and nursing leads as well. I'd really like to extend that more to EDs as well, because they do the transfers and they do the reforms to us, but we have got those links. We just need to kind of make them more established. So that's the first place that we would share that data at the network transfer forum. We've also got our clinical advisory board as well, which has got representation on there from Johnny Hammond and James Thomas as well, from a wider picture, so we can share that data that way as well.
Jenny, I'm sorry, I missed your question because it cut out the signal a little bit. I'm sorry.
That's okay, don't worry. It was more about, and I might have missed it because my signal is not doing well, was more about, Amy, how those going through the certificate, how they found the change, or I guess you don't know a before and after, really, do you, to compare? But
yeah, I think with the people that are on new to care, they have a lot of support, and they have their peer-to-peer learning because they're with each other for 3 weeks. They're going through the care certificate. They bond really well because none of them have any care experience, so they have that, you know, in common really when they start the programme. And then when they start doing their work with the taught sessions with us and with the national e-learning for health platform, we just manage it. So we give them 12 to 16 weeks to complete the care certificate. So from both programmes, whether it be the face-to-face new to care or the virtual programme, they have a good length of time to complete. The virtual pathway, they do tend to have more experience because they're already in the trust, they're working within the trust. So they do tend to find the completion easier, which is why we revise the model to more of a consultancy for that pathway. But the team are always on hand to help them, and they get a lot of support at ward level as well, so it's never really been a problem.
Super, thank you. Thank you both. So any more? I think we're done. Got a few minutes before we time out. So I just thank Alison and Amy again. Fantastic presentations. Absolutely classic for a Friday report out, seeing the improvements we're making across the trust. And Alison, please, if you could just ping me and we'll try and set something up to talk about outside of here. That would be great. So thank you, everyone. Enjoy the rest of your Friday and hopefully a not too wet weekend. Take care, everyone. Bye now.
Thank you.
Thank you.
Bye.
Bye-bye.